So doctors here often are defaulting to telling women that once a C-section, always a C-section, as you mentioned, Divya. It's not strictly true, but it simplifies things for them. If you keep everyone on the surgical pathway, there's less unpredictability, fewer perceived risks. Plus, from a financial perspective, two surgeries mean two full bills. And culturally, many families themselves aren't keen on VBACs. There's that underlying fear of what if something goes wrong.
This is the Birth Agni podcast, the fire that brings us alive, that burns myths and opens a channel of authentic natural birth stories. This show debunks the many myths of the medicalized births, showcases the plethora of choices a pregnant couple can make to embark on their empowered birth journey. I'm Divya Kapoor, a certified birth and lactation counselor and an aspiring traditional birth attendant. Let's get the flames blazing high.
We are facing an all-time high numbers with our surgeries in the country. 14.3% in public hospitals and 47.4% in private hospitals. And this is the data I get from one of the articles, C-Section Surge in India, uncovering the impact of profit on childbirth by Dr. K.S. Uplabdh. I was very happy to find this article because it spoke about the business of birth, the aspect of convenience over the health of the mother and the baby, and a lot of other issues that are not highlighted in the mainstream. And he speaks about them from a place of evidence and trust and empathy for what's happening and what will be challenged very soon. So we have today Dr. Uplabdh Gopal. He's a medical doctor, health policy researcher, currently serving as an associate fellow with the Health Initiative at the Observer Research Foundation, ORF, which is one of India's leading think tanks. He has written numerous research papers, articles, and journals. He has contributed to national and global dialogue on universal health coverage, and he has some incredible insights for us on various topics: VBACs, ultrasound, surgeries, and the impact of preparation for birth, the impact of the emotional side of preparing the parents for if in case there is a need for surgery, and a lot of other things we go in depth with him. Let's dive into it. So, hi, Dr. Uplabdh. Thank you so much for being on the podcast. It was a pleasure to go through your articles and all the work you've done in the field of medicine, trying to bring awareness regarding various issues, one being the business aspect of childbirth, which was such an elaborate, wonderful article that I read. And I was like, no, I need to get in touch. And I sent in a request, and you were kind enough to go through all the topics and the questions that we were to discuss. And you were okay, you were on board. So thank you so much for coming on board.
Glad to be here, Divya. I've been looking forward to this conversation. Thanks for bringing me in. It's a topic that really needs more public space.
Yeah, absolutely. Absolutely. So in one of the articles you wrote that C-section surge in India, actually the name of the article is C-section surge in India, uncovering the impact of profit on childbirth. So herein you speak about the business aspect of birth, which is not very well known. Again, and the rising rates of C-sections in India, that could have really been normal births. And these women are left thinking that, oh, my body failed me or something happened. Even before we go on to the C-section rates in India, how did this field in itself interest you? I know we were speaking about it before, but I wanted to also bring this back into the conversation here.
So, Divya, I'm a medical doctor by profession, and during my medical internship years, I had the opportunity to work in an OB/GYN ward and had also the opportunity to undertake various research tasks around the field. And that is where I've had first-hand exposure towards how an OB/GYN ward operates. And after that, I've joined Observer Research Foundation, which is a geopolitical think tank under the health sector. And I am there basically working as a broad policy sector researcher. So this was something that was brought to my attention, and I thought it's a good topic to write about. Yeah, so
Yeah.
that is what brought me to your platform here as well.
Yeah. So, what do you think, Dr. Uplabdh, are the real reasons behind the rising rate of C-sections? Is it just, and what do you mean when you say the profits are involved in the business aspect?
So that's a really important starting point, because there's this idea in public imagination that if C-sections are happening, it must be for some medical reason. But when we look at the numbers in India, especially private hospitals in cities, you start to see a very different story. Rates are hovering around 47, 50%, and in some places it's even higher. So why is this happening? The first layer is quite simply economics. So a C-section is just more profitable. It costs more, it's quicker, it fits better into a hospital's workflow. Doctors can plan their entire day around it. You don't have to be on call at 2 in the morning waiting for labor to progress naturally. That kind of convenience has value, at least for the system. Yeah. But then there's something else I think that doesn't get talked about enough, is what I'd call the psychology of modern healthcare. Hospitals today market themselves almost like hotels. You see terms like premium birthing suites and labor lounges, and with that comes a certain expectation, controlled timing, predictability, even a kind of curated experience. That pushes both the doctors and the patients towards choosing C sections because it feels on the surface it's more efficient, more modern. That is why. There's also the legal angle, what we in the field now call defensive medicine. I've had conversations with obstetricians who say quite openly that they'd rather perform a C-section than risk a bad outcome in a normal delivery and have the family come after them later. Especially in high-end private setups, patient complaints and lawsuits are now part of the background noise.
Hmm.
And then this might surprise some listeners, but it's also about family preferences. So especially in metro cities, families do sometimes request a C-section upfront, whether it's wanting to avoid the pain of labor or picking a date that aligns with an astrologer guru's chart. These are real conversations that are happening in hospital rooms today. So when people ask why so many C-sections, it's not one reason. It's a whole ecosystem, which includes finance, convenience, legal caution, and a patient demand, and they're all feeding into each other.
Yeah, so when you speak about lawsuits, and that's, I think, one of the very, very primary reasons of not waiting and starting an induction and just getting the baby out as soon as possible. So, do you think this lawsuit, and also, do you think that even with cesareans, babies don't die? I mean, there's news every right, left, and center. I mean, when you Google it, you realize, okay, babies die with C sections as well. So, why is this lopsided regulation? The regulatory system in itself is not helping both the doctors and the parents with the lawsuits the way they are being done today.
I would say that C-sections are not necessarily harmful. I think we should be very clear on that, that C-section do saves lives. Regarding the regulation part, I don't think people are just pushing. I think it's a patient's right to demand a C-section,
Yeah, yeah,
Yeah,
yeah.
so you can't just really, if someone wants a C-section up front, it's an elective abdominal surgery, right? So a doctor cannot just deny a patient's right because it's something called patient autonomy. Yeah,
Absolutely, absolutely. What I meant was that there are lawsuits for doctors if the baby dies,
yeah,
say, but with a surgery, that's the last resort they tried. So they kind of have, okay, I tried everything, So with a doctor, if there's a lawsuit, the doctor might be like, okay, the questions might be like, oh, why didn't you go for a surgery? So if there's anything written, the doctor pushes for the surgery because that saves them. And it's not really in the best interests of the mothers. So from that perspective, I wanted to ask that if the regulations were a little more nuanced and helpful in the way that it doesn't push unnecessary surgeries, not the ones that are needed. They're absolutely needed. It's a boon.
see, there's no regulation as such. Let me give you an example. Say, you know that people get fever. Like it could be mostly a viral fever, but doctors still prescribe antibiotics for a viral fever.
Hmm.
And
Hmm.
sometimes the courts have asked the doctors ki what is the background of why are you prescribing antibiotics for for viral fevers, right? So the background is something like superseded infections during viral infections, because virus has reduced the immunity of the body and then the bacteria is wreaking havoc. So that is why we're
Hmm.
prescribing antibiotics. But I think it could be mostly as a placebo effect, that the doctor has given some medicine to the patients. In a similar way, basically what I'm trying to say is whatever the doctor can justify doing
Hmm.
is something. So if you're saying there should be a regulation for something like why did he pick breech mein he picked c-section or something. If the doctor can justify why he did that, then I think
Hmm.
even the regulatory bodies cannot say anything, even the
Yeah.
courts have to accept that it's given in so and so book and the doctor has done it with medical reason.
Yeah. That was precisely my point, that surgeries save doctors because they can build a case around it. Maybe not normal birth, because then you're waiting. There's definitely far more observation. There's a lot of fluidity to waiting for labor than going for surgery. You can always justify a surgery in case of a death. So that's what I was thinking as well. So would you like to also speak about VBAC? So in this article, you also wrote about the fact that VBACs are not very well received in India at the moment, and there's always this myth that's out there, and that's something we work on with our childbirth classes. Once a surgery, always a surgery. So how do you think? So we do childbirth classes. We do bring women all the research based information. We try and teach them the physiology. How do you think parents who are listening to this should approach birth and information about birth from legitimate sources?
So uh, that's something I find both fascinating and frustrating. VBACs, which is for our listeners, vaginal birth after C-section or cesarean, which is a medically safe in many cases. Globally, places in like the United Kingdom or the Netherlands actively encourage VBACs if the clinical condition is right. But in India, it's rare nowadays, like 7 to 10%. And honestly, a lot of that comes down to system inertia and misinformation. So doctors here often are defaulting to telling women that once a c-section always a c-section, as you mentioned, Divya. It's not strictly true, but it simplifies things for them. If you keep everyone on the surgical pathway, there's less unpredictability, fewer perceived risks. Plus, from a financial perspective, two surgeries mean two full bills, and culturally many families themselves aren't keen on VBACs. There's that underlying fear of what if something goes wrong. What worries me is that so many women don't even know VBAC is an option. If you walk into an average maternity center in India, you won't see posters or leaflets talking about it. It's invisible by design. Now when it
Oh,
comes to where women are getting information, more and more it's shifting online. Social media, YouTube channels, birth podcasts such as yourself, which could be a double-edged sword. There are some fantastic platforms out there like this one for instance, but where people are trying to put out real evidence-based content, but alongside that there's also a flood of unverified advice, random
right.
influences, even product marketing which is disguised as health information. I think it's actually quite overwhelming for someone trying to figure this out on their own. In the absence of clear communication from hospitals to or doctors, people end up piecing things together from what people just randomly search up on Google and from Instagram posts, all the Instagram scrolls and things that people see, which is not how it should be. That's where community-based initiatives they really help. Midwifery groups, antenatal educators, WhatsApp support groups, and even patient support groups that stick to verified guidance. But I'd say we're still at a very early stage of that ecosystem in India. There's a long way to go before evidence based, women centric information becomes the default.
Yeah. No, I love when you said that it's hidden by design because that's true. I mean, I didn't think about it. It's never spoken about. No woman is told, okay, you had a surgery this time, we understand you had to undergo a surgery, probably next time, you do have a chance. Don't think it's done forever. It's never something that is built upon her even from the beginning. It's just that she's left thinking that her body failed her, and she's thinking then probably another time it will fail her altogether. So yeah, wow. I mean, and then with all this, we also come to a topic which is very strongly linked, is obstetric violence. Now, it's coming to light from the Western, again, the Western media and the Western doulas. I used to hesitate using the word because I have doctor friends, and I would be like, okay, obstetric violence. But I, of course, because I cannot stop myself from bringing out authentic information, and that's my job. So, obstetric violence is pretty much out there, and it is now gaining popularity among women in India, and they've started looking for respectful maternity care. And that's how the Sanctum Birth Center in Hyderabad and Asrika Birth Center, they popularized themselves. In fact, Janvi was there on the podcast and she said that's how she birthed in Sanctum, because she did not get one place where the evidence based practice was being done in a hospital, not one. And she is somebody who has influence, and she could have gone to US and birthed, but pretty much US also is not following the guidelines. So episiotomy was something that was her problem. She said it's outdated, I don't want one, but she couldn't find a place that supported her. Sanctum was one that supported her, and that drove her to start a birth center altogether. So now, with respect to respectful maternity care and obstetric violence, would you like to speak about it, like share your thoughts on it?
Yeah, thank you for the question, Divya. So I think it's important that we talk about obstetric violence plainly, because while the term might sound heavy to some people hearing it for the first time, what it refers to is actually very familiar to a lot of women across India. It's not just the extreme cases, it's all the everyday disrespect, the unnecessary interventions, the lack of consent in how maternity care in India is being delivered. So, if we step back, maternity systems in India have largely been built around volume and control rather than personalized care. So, you get situations where women are shouted at during labor, sometimes even slapped, moved through procedures without clear explanations, told to bear the pain, or pressured into things like episiotomies or C-sections without, taking real consent. For some, it may be verbal abuse. For others, it could be physical handling, that is basically disregarding one's dignity. And all of this falls under the broad umbrella of obstetric violence. What's striking is that people have really started naming it now. 10 years ago, these were just described as normal hospital experiences. Today, women are coming in more aware, more vocal, are demanding what's now being called respectful care. That's exactly where places that you mentioned, like Sanctum, have positioned themselves. Their whole pitch is that they offer what's missing in the mainstream hospitals, care that centers around the mother, not just the institution. And it's not like they're just doing it as a branding exercise. It also reflects that there's a genuine gap in the services market and how it's structured. In my view, this is a part of a wider shift, where patients are no longer just satisfied with just having a baby or just survival or just safety. They're talking about the quality of the experience, and that shift is very much needed, because respectful care should not be a luxury add-on. I mean, respectful care should be very fundamental to a good and healthy outcome.
Absolutely. And when we think about the physiology of birth, a woman needs to be respected in birth. Otherwise, her oxytocin will not flow very well. And then all the fear comes in, and her labor stalls, and then all the lack of progress and all other medical interventions pitch in. And that's one of the things we were discussing before we started the recording, was the lack of understanding of physiology in the mainstream medical system. It is so programmed to work on interventions and management of birth in itself. Yeah, that is sort of very sad, I'd say. Sad with the fact that the world is already shifting towards it and we are still looking at it. And that's, if you're looking at it, I'm happy that we are at least approaching it from that perspective. And you also, in one of your articles, you said that, and it was about child health in urban areas. And you
Yes.
said that we can strengthen child health in urban areas in India by strengthening the urban ASHA workers and the UPHCs with community engagement. Now, that's also something that's very close to my heart. When we
Mhm.
talk about local community, we often forget our dais.
Yeah.
So, our local dais that were birthing babies, even very recently, I had a woman who lived like right behind my house. She had two children at home with a local dai. And I met a few while training just to, get to know how they function. So we have discarded them. We are bringing in new nurse midwives, but we are not absorbing their traditional knowledge. And we were talking about castor oil as well, which you were speaking about, that say castor oil or arandi ka tel is very
Yeah.
very traditionally used by local dais, and now the West is bringing it back, and the Western midwives use it. It's a part of their midwifery training. It's a real tool. and can be used, but it has not been brought back. So my question really is, one, when you spoke about the local community involvement, what did you mean by that? And then, do you think there is a space for us to absorb our local dyes before the knowledge is lost?
And that's a really good question, because when we talk about community engagement, especially in urban child healthcare, uh, people often imagine it like just another checklist item. You organize a few camps, put up some posters, but genuine community engagement, that is, it goes deeper than that. It's about recognizing that health isn't just delivered by a system. It has to be lived, it has to be understood, it has to be, and it is passed on through families, neighborhoods, and people who carry what I'd call working knowledge, as you mentioned. When I wrote about strengthening urban ashas and the urban primary healthcare centers, what I meant was that they can't function in isolation from the communities that they serve. It's not about having just this one health worker who's visiting a slum and has a clipboard. You have to build trust with people, as you mentioned when we're starting about rapport building. You have to spend enough time with them to actually listen, and you have to value the knowledge that exists already, like locally. And you've touched on an interesting point about the local dais, who are traditional birth attendants for our listeners. For decades, public health systems in India have dismissed them outright. The thinking was that if you haven't studied medicine formally, your knowledge doesn't count. And now, ironically, a lot of the things, as you mentioned, that the dais used, like castor oil, for labor preparation or for certain postnatal care practices, they're resurfacing through global health trends as if there's something new. It's like, once again, it's like the Scandinavian shawl kind of thing, that people are calling, or like Pradas or something,
Yeah,
Kolhapuri slippers,
Kolhapuri
that
chappals.
kind of thing. That disconnect, this attitude of, as you mentioned it in your email briefing, about being well read over well lived, as you put it, is
Yeah.
something we need to address consciously, because urban health systems, especially, have become so hospital centric, so protocol driven, that they often miss out on what's already present in people's homes and people's neighborhoods. Community engagement to me is not just meaning ki we disregard that local wisdom, but integrated responsibly, whether it's through involving experienced women, who people who are experienced in doing health promotion activities, recognizing informal caregivers, which is a big thing as part of the ecosystem, or simply creating spaces where ashas, the UPHC staff, and local residents, they can meet regularly without that power imbalance.
Yeah.
End goal should, like, just besides the better statistics that we'll get from doing such an activity, it's important that there's a system that people actually trust enough, to put to use. And for that, local knowledge has to be treated as part of a solution and not like something as a relic from the past.
Right. That's so important where you said it's like a relic from the past. It's like all the wisdom of the midwives will be spoken about as legends, and then they were gone by because we never preserved them. Absolutely. No, no, wonderful. It's also the with the shift to the hospitals, there is definitely with ASHA workers also, they're not able to work to their best because now they have to push the woman or pick the woman and take her to the hospital, even if the hospital is far off. The convenience, it's she doesn't have the like she cannot commute very well. She's unsure. She's like, I'll better be home because I've seen births at home and I'm fine. Definitely there's the safety aspect, I understand, with the medical system wanting to push everybody, but without infrastructure and not utilizing the existing supports that is already there, we are still trying to build a system without the foundation, and it's not helping us. In fact, I was reading this our 5-year report, and I think our neonatal and maternal mortality did not improve very well as compared to our interventions that we've had. So I spoke about, I don't have the numbers right now, but I spoke about it in one of the episodes. It was, I think, from 2021, 2022, not the recent ones. Alongside, now we spoke about surgeries, right?
Yeah.
And we spoke about, and you said that we have to first of all talk about them as a boon as well, in which it is like it's not something we are fighting against. What we're fighting against is unnecessary and unjustified surgery, and which would be bad for any part of the body, let alone childbirth. But that's a boon again. You highlighted the need in one of the papers with respect to surgeries, You highlighted the need to prepare the patients, and you spoke about that if we talk about this to patients, and in a way, to me, that felt like informed consent, which is very well missing in the medical system. That the rising rates of postpartum depression and other aspects will be covered, and that conflict will be resolved. So, yeah, please explain that aspect as well.
Yeah. We often talk about, surgeries in terms of technique, safety, but rarely we talk about the experience, like what it feels like for the patient before the surgery and after the surgery. Especially with abdominal surgeries, which is a major operation like C-sections. Even when they're unavoidable, the emotional preparation is often completely missing from the process. Right now, the system is set to move quickly. A woman is told she needs a C-section, there's a signature on a form, and within a couple of hours, it's done. But that gap being between being told and being wheeled in can be incredibly, challenging, overwhelming. You are dealing with fear, uncertainty, even questions about whether you made the right decision. Ideally, hospitals should have a built-in, structured counseling before planned surgeries. Not just a checklist about, fasting or anesthesia, but actual time with a midwife, a nurse, or even a psychologist to talk about what's happening, what they're going to go through, what recovery feels like, and what kinds of physical and emotional changes to expect. It doesn't have to be complicated. It could be as simple as a short pre-surgery class or like a one-on-one session, especially for elective procedures. Some places abroad have already started doing this as standard practice. Patients get a full
Hmm.
briefing, both medical and this also emotional. In India, we haven't quite reached that level of routine support yet, but it's something I believe can make a real difference, particularly for first time mothers or people without strong family support systems. At the end of the day, it's about seeing, patients not as cases but as people who have very real fears. That is a mindset shift that needs to happen for hospitals so that they
Hmm.
start taking people more seriously.
Yeah, absolutely. And that brings me to this point that hospitals are already loaded with work. And I think when you spoke about convenience in surgeries, you also spoke about how it's easy for the workflow. Because, of course, we don't have as much bandwidth with neither the
Yeah.
doctors nor the nurses to be able to give that much time to one person. And labor can go on for 2 days sometimes. And so, from that perspective, I wanted to ask you, I think you did highlight this as well in one of your articles, that there is a real issue with how we are looking at the frontline health workers, and how do we then improve the medical system in itself in terms of workflow, so they have the time, energy, and the relaxed attitude towards birth, and to be able to take that much amount of that time to be able to build that great service relationship with the women. It's a service at the end of the day. And yeah, so how do you think that what are the challenges, one, with the medical system, and then how that can be bridged?
So I'm glad you brought it up because very often when we critique the maternity system in our writings, in our research papers, we forget that the people inside it, doctors, nurses, support staff, they're also operating under very enormous pressure. All these statistics come out that say India has X many doctors per thousand population. We're doing so good, yeah, so bad, according to who's deciding the criteria for being called a doctor in India. Yeah. So it's easy to say that the system isn't patient centered, but truth is that it isn't particularly doctor or nurse centered either. In a busy public hospital, for example, you could have one obstetrician, one, just one, managing 20, sometimes 30 deliveries in a single shift. So obviously that means that the system isn't set up for quality care. That is a system which is set for volume, which I mentioned earlier. And in that kind of environment, it becomes less about practicing medicine as an art or as a calling, and it is more about just getting through the day without having a major crisis. The bureaucracy is its own story. Every delivery comes with a file, every C-section comes with three more. There are audits, paperwork trails, government reporting requirements, insurance forms if you're from the private sector. And while all of that might serve some administrative purpose, it often does so at the cost of, I would say, a human interaction that patients expect and deserve. A nurse might know perfectly well uh, how to comfort someone in labor. But if she's got so many forms she has to fill and stack up, and then another patient is waiting, then there's no room left for that instinct, to play out. And again, as I mentioned earlier, of the legal angle, doctors today, they're practicing under a kind of very mild or low grade fear. It's not like medical complications only, but also of litigation, of complaints going public on social media, of reputational damage. Like if there's, even before going to courts, there is something called the social media trial, so doctors are very afraid of that. That kind of pressure narrows your field of vision. So it's not just key best for the mother in a holistic sense anymore. People have moved beyond that, and it's about what keeps everyone covered legally and financially. So the difficult part is that most people who go into healthcare don't do it for that. They don't come in for the forms or the fights. They come in because they want to work with people, to help the people. But the system isn't always set up to let them do that in a way that is, I would say, feels meaningful. So when we talk about improving maternity care, so about better outcomes for women and babies, it should also be about protecting the people who are providing that care. We see all this kind of violence against doctors, so I think it's very important that we see that our healthcare workers don't burn out and don't lose faith in the system, and because ultimately it would be the patients who would be paying the price.
Absolutely. No, love that. And it's true. I mean, sometimes they say you're. So, of course, I'm critiquing the doctors all the time. So, I'm like, because you sometimes promise things that won't happen. I mean, for example, promising, okay, the labor will last this long, or promising you're going to have a baby at the end of the day because now you're going to plan a surgery and stuff like that. So, sometimes it plays against you, and then people are like after you. And so, I'm like, that's the problem, right? And it's sad. I mean, nobody should go against the doctor. They're still trying to help you. And there's again a lot of, like you said, the patients are also not prepared sometimes to receive the kind of care. So they want an answer, they want a number. Like, you're not a good doctor if you give me the time that my baby will be born. Doctor cannot know. And that's where preparation comes in. So yeah, so do you think bringing in all other like health workers, maybe even like, for example, I'm an independent worker, I independently coach and prepare parents for births, and one of the reasons is because I don't want to be under the government protocol or the hospital protocol that I can't speak against episiotomies because that's a hospital protocol. No, I will speak against it because it's not research backed. And anyway, eventually they will let go of it. So yeah, what I really wanted to say is, eventually, do you think bringing in all the independent workers, increasing the workforce, again from the regulatory body, sometimes I also feel, correct me if I'm wrong, Dr. Uplabdh, that our administrative people do not have very good knowledge about how the healthcare system works, or health in itself, or a particular system itself. They are still looking at building protocols and regulations from a very administrative place. So if we bring in somebody who is more from the medical space, or even researchers like you, do you think things would change? Like, how do you see this?
Absolutely. That's something I've seen firsthand as well. And I agree with you. I would suggest that there should be something like a health cadre. Like it was recommended a lot of years back. Like we have the IPS and the IAS. So a similar cadre for health officers or healthcare officers who should go into this field. Currently, even in the administrative process, there are not a lot of people with healthcare background. So I think that is something that could be really beneficial. And I would like to say that it's a big system, but small changes have to start at the ground level. So I hope that this conversation nudges more people to think about both the sides, patients and providers. And I agree that we have to bring in everyone into the system. It can't just be a black and white conversation, it's doctors or patients, but you need to bring in other people like the local dais, you need the birth attendants, and nurses, psychologists. Yeah. And I would like to add something that I was recently seeing in the news. I think it is something tangentially related to this question, is that I saw, like, I think that the language around birth also matters, you know
Yeah.
yeah. So I was reading this today on Google News, right, about actress Richa Chadda. She shared a post that celebrated her daughter's first birthday,
First
and
birthday.
she referred to her delivery as natural birth. That sparked a mini online debate. Some trolls argued every birth is natural, and she should have just said vaginal delivery instead. So the actress had responded, but I think her line stuck with me about my vagina, my baby, and my words, because of not the celebrity angle, but because it touches on something deeper. So birth is not just a medical event for many women; it's a very deeply personal journey about basically being physically, emotionally, culturally, and how we talk about it shapes how people feel that they can own that experience. Terms like natural birth resonate exactly because they carry meaning beyond biology. They signal autonomy, emotional agency, even defiance. That's why, respectful language matters in maternity care, and why choice matters too. So when doctors or systems insist on, or the administrators insist on, like a one type of language or path, whether it's a once a surgery always a surgery, or you can't just say natural, they're closing off the conversation like once at all. So what this actress has done was like wider with that one sentence. It has opened a space for the women to define their own birth stories. So I think bringing that nuance into maternity systems matters. So not just surgical rates policy, we have to recognize the birth language, the words, the tone that we use in hospitals, in counseling, in antenatal classes, and we have to bring all these people together. I think one ideal suggestion could be adding more stuff about patient rights and patient ethics into the medical curriculum for the budding medical doctors, and we can see how all of this shapes how women see themselves through that process, and that in turn will shape the outcomes, because when patients will have a real sense of control, and they will be able to see, real health effects.
Yeah, no, I absolutely love when you brought that aspect of Richa Chadda's. I was reading, I was like, I follow her on Instagram, so I was just reading her story. I didn't go through the comments, but absolutely, today you can't call your normal birth normal because everything is normal.
Sunil Shetty also got into trouble for the same issue, because he said that his daughter Athia, he was very proud of her for having gone with the normal birth, as he called it, over a C-section, and he was very proud of the fact. I think he got into trouble and he had to apologize for saying so.
Yeah, but I feel sad for that as well because it does take immense hard work. And again, it's not the women who had a C section, they failed, they did not fail. So it comes from a very insecure place that I failed, my body failed, so let everything be
Yeah,
normal. We would never call a kidney surgery that saved your life normal. It was still a surgery. You underwent a surgery, and that's a reality.
yeah,
Yeah, we need to bring that, and that's how we bring in care as well. So when we say you underwent a major abdominal surgery, and again, like all the things you said through the podcast, they all hold so true when you speak about counseling the parents and counseling them through these major life changing processes. They're better placed. There's no fighting about normal, natural, and surgeries,
yeah,
and where do you bracket them. And it's so helpful to again keep the work going, because we're not trying to label anybody. We're just trying to have more and more women go through a normal process as much as it's possible. Of course, when it's not, thank God for surgeries. I
yeah,
mean, it would have been a sad state otherwise. So yeah, thank you so much, Dr. Uplabdh. I've had a
yeah.
good time speaking with you.
Thanks, Divya, for giving me the space to present my views on this topic. This topic doesn't always make the front pages, but this thing really matters. That's where I'd leave it for now. But I'm always happy to continue the conversation.
Yeah, absolutely. Maybe we could sit again together for some other,
Yeah,
further subcategory of the conversation. But yeah, thank you so much for your time today. I had a lovely time.
yeah. Thank you so much, Divya.
There is a field beyond fear, where the body is empowered to take on labor and birth. To land there, it is crucial to take birth education. To enroll into our unique labor and birth preparation course, reach out to us at www.birthagni.com or scroll through all available prenatal and postnatal preparation classes. Thank you for listening, all in the spirit of birth, womanhood, and freedom. Remember, you got the power. This podcast is about physiological birth and does not offer or claim to provide medical knowledge or diagnosis.
Starting a podcast with poor recording tools in the market? It was painful until I found Zencaster. Its high quality audio and video recording, along with the option of a backup, makes it super sturdy and a savior at times. With an easy to use dashboard and super convenient tools for advertising campaigns such as reels and videos, Zencaster is my comfort choice. Go to zencaster.com/pricing and use my code BIRTHAGNI, BIRTHAGNI, and you will get 30% off of your first month of any Zencaster paid plan. I want you to have the same easy experiences I do for all my podcasting and content needs. You may also explore their free hobbyist plan to begin with.